research focused on cost-effectiveness research. And I honestly think with the Mayo Clinic and the University of Minnesota in the state, with all the device manufacturers we have here, we could be a national leader. We could almost be a little NIH, National Institute of Health. Here in the Twin Cities, we have that capacity to do this. But it's essentially to figure out what bang do you get for your buck? And that's an unknown question in a lot of medicine right now. And there's a lot of vested interests who don't want to ever determine that question. A lot of drug trials are rarely done against another drug head-to-head. Instead, they're done against a sugar pill. Why is that? Because sometimes the differences are so small, one pill to another, that it's hard to justify inflated costs for some of that work. And so cost-effectiveness research, any of us can go and figure out with our own values and what we need when we want to buy a washer or a dryer. There's consumer reports. There's things like that are available to help us, even for for me, bizarre things like digital cameras to help me figure out what do I really need and such. We need that same kind of information if we're going to really have engaged, informed consumers participating in their healthcare decisions. So I think that's just absolutely one of the big keys to this. And I'm also really pleased that industry came to the table or were dragged to the table. I wasn't in any of the meetings to know. Congressman McCollum could probably say better, but some of the, you hear people talk about the taxes on the device industry or how the American Hospital Association came up with $500 billion to put in the pool and the AMA came up with so much. They're gaining access now to a whole new market of 50 million more Americans who have health insurance, who are not writing off the costs of that care. And again, it's an example, it's not a free market. And there should be some way of contributing to the commons if they're gaining access to a 15% greater market share through no efforts of their own.
Right. Well, again, I would commend to your attention this summary of the bill, and it goes on for pages, and you can see all the studies, all the demonstrations, all the encouragement for people to experiment, to see how to address the very issues that the question lays out. One thing that I'm, as a public health person, really pleased to see is finally some serious investment in prevention in the bill, both in terms of coverage, as Congresswoman McCollum has already talked about, but also lots more funding going into school-based prevention activities, going into our state and local public health departments to work on prevention at a fundamental level of communities and the risk factors in our communities that are leading to all the health problems to begin with. And even though it's a lot of money for public health standards, it's still a drop in the bucket. We spend less than 5 cents out of every dollar on anything whatsoever to do with prevention in the United States. And that's one of the reasons why our health statistics are so much worse than a lot of other countries who balance their dollar differently and spend a lot more on prevention. So this investment in this bill maybe gets us up to another couple of cents on the dollar. Still not, in my judgment, enough of a balance on prevention, but it's for public health a far bigger step than we've ever taken before. So we'll continue to build on that.
Well, I would agree with what the other panelists said. There was one part that hasn't been touched on, and I'll speak to it. It's an uncomfortable topic here in the United States. It's an uncomfortable topic anywhere in the world. And that's when a loved one's dying. I was shocked. I was outraged. I was vilified. Because somehow or another, I was promoting death penalties. What we were allowing is for dignity at a time of death, and I do take this very personally because my mother gave me a great gift. She gave me life, and the second gift she gave me was allowing to provide her hospice care when she was dying. And what this bill was trying to do was giving more opportunities for families like my brother and sister and I had with my mother. And that was for my mother to talk to her doctor and to make decisions upon what she wanted to do when her cancer came back and it had spread so far her life. The saving options were over. And let me tell you how it works, folks. works this way. Your mom signs up for hospice. And then one day, because you provided it for other family members, you find your feet going cold. And you make the phone call after you've talked to your mom. It's time to call someone in. It's time to call the hospice nurse in. Let's check out and see what our options are. Our options over that week were putting a hospital bed over to my sister's and having her spend Christmas over there. When the pneumonia came up, the option was that the doctor would send a nurse over to the house, be with my mother, take the temperature, figure out what we needed to do. She could go to the hospital if she wanted to. She could start antibiotics at home if she wanted to, or she could choose to do nothing. She chose to do nothing, and we honored that request. She died a very peaceful death that morning, week before Christmas, eating a Santa ice cream, making us swear that we would not tell her grandchildren she had ice cream for breakfast that morning. She gave me 2 great gifts. I think every family should have that as an option. And so the only thing we tried to do was to provide families options and dignity by having Medicare pay to have that discussion with their doctor. That's not in the bill. And I'm going to work really hard to restore it. Thank you.